This is all of it. I'm Tiffany Hansen in for Allison Stewart today. Well, in our previous segment, we were talking with a doctor about her medical training, and now we're going to turn our attention to a new medical school curriculum from an institution on Long Island that aims to raise the next generation of doctors to be competent, compassionate, and collaborative. Dr. David Elkowitz is the Associate Dean for Academic Programs and Educational Culture at the Zucker School of Medicine at Hofstra Northwell. He's also the director of the Academy of Medical Educators, and he joins us now to talk about the Zucker School's innovative approaches to medical school. Welcome, Doctor.
Hi, how are you?
Doing great. Thank you. All right. So in that last conversation, we talked about see one, do one, teach one. It's a common expression, as we learned. So I'm wondering how Zucker's curriculum stays true, if it does, to that three-tiered approach.
Oh, 100%. We have very small group classrooms here, a very, very small class size. So our students, right from day one, not only learn medical education, they're exposed to patients, but they actually go through almost a teaching fellowship. From day one, they start teaching each other about things they learned the night before, things that happen in the classroom. So, as we, have a discussion over the next few minutes, you'll start seeing how this concept of not only learning but teaching is woven through our entire four-year medical education program.
We talk about this as a new approach, so I'm curious what was lacking in the older approach, the more quote unquote traditional approach to medical education that you think needed a little bit of tweaking.
Yeah, first of all, I came through that old medical type of approach, more of a traditional type of approach where, you sit in a classroom for 8 hours a day and you have a professor or a sage on the stage, so to speak, that's essentially delivering information to learners just passively sitting there in the classroom trying to collect all this information in order for them to, learn it or at least be introduced to it. Here at our school, we're a student-centered curriculum, a very active curriculum where our students essentially develop learning objectives and learn the material in part on their own, and then come into the classroom here and apply it with professors, patients, right from day one. So it's a very active approach. Students, when they come here to our school, not only learning and applying medical information in real time with patients as certified EMTs right from day one, but they're also teaching each other as well. So why this shift? You know, Technology over the years has changed. When I went to medical school, in order for me to stay on the floors during my clinical years and stay with the team, I would absolutely have to know a lot of information, memorize a lot of information, and have it at my disposal in order for me to stay with the team. So I wouldn't have to go down to the library and look up information I should know. These days, we all of us are walking around with cell phones, and we all have the medical information at our disposal, at our fingertips. So really, when we're on the floors with patients and doctors, we need a different skill set. How do we apply? We can get the facts very quickly, obviously, but first of all, where do we get the facts from? So scrutinizing sources is something that we teach our students right from day one, how to go about doing that, how to apply that information, those facts that we have at our fingertips to the patient right in front of us. That's very, very important. So, technology has really guided medical education from a passive approach to much more of an active approach.
Specifically, when we're talking about technology, what are some pieces of technology that have really made it so that parts of that older style of education are just no longer useful? Or in fact, is there a specific thing? I know we talked in our previous segment about we used to see on TV doctors carrying around clipboards, right? Now everything is a medical record
Yeah.
on the computer when you walk in. A concrete example like that of another way maybe that a patient might see technology changing the way doctors are interacting.
Oh, as you were asking that question, I had a big smile on my face because when I was a resident and fellow and even new attending as a pathologist, I would have my pockets stuffed with notes and cheat sheets and review books and all sorts of sources, just so I have that fact at my fingertips. And patients would absolutely see that. And our reliance on that information, now in these days, whether it's all the interventions that are obviously electronic and technology forward, but certainly the facts that on our cell phones we have at our fingertips that are evidence-based and the sources are good. We can get that information quicker and much more reliably in front of the patient. So now, what do we expect out of our students? Our students have that. We don't have to memorize all this stuff that we had to do 20, 30 years ago.
Mm.
But how do we apply those facts to have better patient outcomes in real time? The patients absolutely see that. And, their visits are more efficient. And maybe, the technology is helping if used in the right way for much better outcomes.
I'm wondering though, like, for example, if you are speaking with a physician about a particular ailment and you
Mhm.
say, my ankle hurts when I do this, when I do this, doctor, how is it for the patient experience when the doctor then just immediately looks at their phone or looks at the computer versus the old days, when Dr. Elkowitz would just rattle it off the top of his head?
You know, at the end of the day, the way a patient looks at their physician, it's not just, where they're getting the information from, whether it's a phone or whether it's from a review book, or maybe they have to excuse themselves and go down to the library. At the end of the day, a patient's confidence is going to be predicated on first the rapport that the physician builds with that patient. The communication, is that patient being listened to? How transparent is that,
Mm.
doctor? And is that doctor becoming a partner with that patient to figure out the information that they need to be treated appropriately? So at the end of the day, that's really the secret sauce. Listen, I have a personal experience. Right now I'm a stage 4 cancer patient
Mm.
being treated, and walked into one of my visits and asked the question of my doctor, and she didn't know the answer, but she goes, you know what, let me grab my computer and let's figure this out together, and just rolled her chair around with me sitting on the table, with my robe on, and we kind of figured it out together. So the technology is important, and it certainly facilitated change in medical education. But the reality is that a patient is only going to look at their physician with trust if they know that they're being listened to, if the physician built rapport, and if the physician is knowledgeable and it's, evidence-based.
Mm. First of all, best of luck with your recovery.
Oh, everything is going well.
Okay,
Thank you.
great, great.
Yeah, yeah.
Second, let's talk about this memorization a little bit, just from the perspective of teaching, because I know you say that we've taken some of that off the table for medical students. They're not required to memorize as much or keep as much in their rolling around in their pockets on little pieces of paper, pieces of paper that they can't keep memorized. How do you know if they're not doing that? How are you, as an educator, assessing their knowledge?
That's a great question, because I'm faced with having to give evaluations to medical students all the time, and it appears to be a conundrum, but it's really not. Many times we'll actually give the facts on an examination. Listen, I'm telling you that these are the facts, but we'll ask a question in a way that they would have to take those facts and apply it to solve a problem. So what we're really assessing is critical thinking and problem solving with a set of facts that they already are given. So we kind of flip it around. And, when they take boards, that's essentially what boards are testing now. Back in my day, boards were very fact-based. Do you know this or do you not know this? Today, yes, medical information, they have to know a certain amount of medical information, certainly. But a big part of what they're being tested on is for them to be able to answer a kind of a higher order question to test their critical thinking and problem solving.
Mm.
So very, very often we'll give them the facts, and we are actually testing not only how they problem solve, how they're going to critically think, but also their communication skills, how they're going to talk with the patient, how they're going to explain these tough concepts in a way that a patient is going to be able to understand. That's how we go about testing here. So to that end, we have a lot of essays. We have oral examinations, which is a very, very unique thing in medical education, especially on the medical school, the UME education.
You talked about we talked about the technological changes and how that sort of necessitated this change in the way we view medical training in med school, in residency. I'm wondering how much societal changes are also pushing the need for change here, because we can imagine a day in the past when the doctor, usually a man, was really his advice, his knowledge was taken as gospel, right? You do what this person says, you believe everything this person says, and he's going to sort of hand it down to you as an edict, and you'd better do it, otherwise, tough luck. And obviously that's not the case anymore, and that's not what people expect anymore, and that's not what people have become used to or are demanding. And so how much of what we see in the changes from medical school are precipitated by that change in the culture around physicians, people who are becoming physicians, the way we are expecting them to behave?
It's important that physicians, certainly have the heart, the spirit, that when they see a patient, that it's a partnership. So I think that's first and foremost. And developing a relationship with that patient built on trust and rapport, that's very, very important. The second thing is that, as you know, half of the medical school class, just in general across the country, are men and women. So, that's a seismic change from, 40, 50 years ago as well. But, again, what makes, I think, Hofstra, the Zucker School of Medicine, unique is that these elements that we're talking about are kind of embedded right in the curriculum from day one. So our students are, very, very sensitive to this whole idea that the patient is, part of the team. Certainly, the patient and the physician have to work together in order to have great outcomes. Trust has to be built. Even as a pathologist, I read a lot of slides, look at a lot of images. Our students have to understand that behind every slide, behind every blood test, behind every image, there's a human being. There's a patient that's worried. There's a family that's worried. And, I think that society expects physicians to be able to function with patients and families in that way very, very differently than 40, 50 years ago, where essentially, like you described, you're just going to do what I'm told, and, that's
Tough
the way
luck.
it's going to be. Yeah, that's
luck.
right. That's right.
Listeners, we're talking with Dr. David Elkowitz, who's the Associate Dean for Academic Programs and Educational Culture at the Zucker School of Medicine at Hofstra Northwell. He's also the director of the Academy of Medical Educators, and we are talking about new medical school curriculum and what that looks like going forward. Do you have questions about how doctors are trained? Are you curious about how doctors talk about risk or death? Where do you think doctors could use more training? You can call us. You can text us at 212-433-9692. 212-433-9692. Dr. Elkowitz will continue here with the conversation in just a minute. We're going to take a quick break. This is All of It. I'm Tiffany Hansen in for Allison Stewart. Stay with us. This is All of It. I'm Tiffany Hansen in for Allison Stewart. We're talking with Dr. David Elkowitz, the Associate Dean for Academic Programs and Educational Culture at the Zucker School of Medicine at Hofstra Northwell. Dr. Elkowitz, we're going to just go ahead and dive in here with one of our callers and bring Dr. Sherman into the conversation. Good afternoon.
Hi, good afternoon, Dr. Elkowitz. I'm an 80-year-old retired geriatrician, actually, and about 15 years ago, I wrote an editorial called See One, Do One, Have One, Teach One, as I was experiencing the onset of acute and chronic illnesses in late in life. And that actually gave me new understanding and new empathy for teaching medical students about the subtleties of procedures, the unspoken issues that occur with some procedures, because I actually experienced them myself. You want to comment on that?
Yeah, I certainly understand where you're coming from. Over the last 8.5 years, I've been experiencing, as I explained, my cancer diagnosis. And, interestingly enough, I teach the pathology of cancer and use a lot of my own slides and a lot of my own images and all my blood work and my entire medical record I use to demonstrate, basic understanding of molecular pathology and cancer. I will say that, this experience that I went through or I'm going through still over the last 8.5 years made me much, much more sensitive to essentially the humanistic side of medicine, even pathology. When I used to take a look at a slide as a medical student, 30 years ago, yeah, it was a slide that I had to memorize. But, now our students realize that that slide had to come from tissue from a procedure that came out of the body. And behind that slide, lives a patient with a lot of worries and concerns. Behind that slide lives a family that's worried, that's wondering what the outcome is going to be. So, in a way, it turned out to be a wonderful thing where our students don't look at static images and slides and all sorts of other things just as kind of isolation. They understand that even a simple blood test, had a human being behind it that was probably woke up and worried about what those results were going to be. So I couldn't agree with you more. This situation certainly made me a little more sensitive to that.
Yeah, Dr. Sherman, thank you so much for your call. Dr. Elkowitz, we have a text here, too, from a Hofstra alum that says, I was a caregiver for my mother when she had dementia, and I think doctors need better training to work with patients who have Alzheimer's. Not necessarily to address the specific training around Alzheimer's, but there is training that would be useful when dealing with Alzheimer's patients that can be taught more broadly, I would think, about compassion, about empathy. And how are you addressing those kinds of kind of softer skills?
Yeah, well, you can't have good patient outcomes without building a rapport and trust. And so how we're developing those skills here is at first we are dealing with a very small class with very small class sizes. And in our case-based curriculum, we call it PEARLS, our students, certainly as they're learning about medical education, including Alzheimer's and the pathology and the mechanisms of what's creating Alzheimer's and how to treat it, our students are also learning the skills of teaching each other, communicating with each other, and then at the end, they do a group and self-assessment on how that session went. And the assessment is a personal assessment on what they know, what they didn't know, and a group assessment on how everybody think it went. And everybody in that room does their own individual group and self-assessment. What makes this unique is that they're actually graded on that. They're graded on the quality of assessments, how transparent, how honest they were, and if there was an action plan that was created, are they going to fulfill that in the upcoming weeks? So, yeah, I mean, Alzheimer's or any disease, has that secret ingredient of, physicians that possess humility, reflection, that possess obviously medical knowledge, but when they know something and when they don't know something and how they're going to look it up and, work in a team environment.
Let's talk with Jennifer at Harlem Hospital here. Hi, Jennifer.
Thank you so much for taking my call, and thank you for this excellent segment. I'm working as an administrator on a prenatal health program at the OBGYN clinic at Harlem Hospital Center, and I just wanted to underscore the critical importance, which we're increasingly aware of, about the social determinants issue. A majority of our patients are tackling such incredibly serious kind of social and economic issues that when they come in many ways, their healthcare needs are so marginalized because they're so oppressed by everything else. And I'm hoping and assuming, Dr. Elkowitz, with the kind of focus that you're putting forth in your program, that is very much a centerpiece. It certainly was part of my training in psychology, mental health, medical anthro, and public health. And I know increasingly it's very much a focus for clinicians. So I'd welcome your feedback on this.
Thanks, Jennifer. Yeah, Dr. Elkowitz?
Yeah, we wrote papers stemming from this curriculum on leadership. We wrote papers on healthcare costs and introducing those concepts very, very early on with our learners. Because listen, at the end of the day, in order for there to be a great outcome, there has to be a right diagnosis. The patient then has to accept the treatment plan, but then someone's going to have to pay for that, right? And so our students certainly are exposed very early on to insurance issues, to compassionate care issues with the drug companies, through their cases. They become certified EMTs right from day one of their medical training. So they're exposed to a lot of what was just described, seeing patients on the ambulances as first-year med students. And so again, what we try to do here is we try to take these types of threads that we're discussing and weave it through a medical education curriculum. And I think that really is a unique part of who we are in order to ultimately achieve great outcomes.
Dr. Elkowitz, another doctor here, Sarah in Brooklyn. Hi, doctor.
Hey, yeah, going along those same exact lines. In my medical education, I didn't receive any education about insurance companies' prior authorizations and any really empowerment to change the system. The system that exists is terrible for so many patients, and so many patients either can't afford the care or get these massive bills that they can't afford and end up going bankrupt because of it. And I just feel like medical education needs to do a better job to empower medical students and physicians to become political, to become lobbyists, to change the system, because the system is just so broken, and we see it every single day.
Sarah, thanks so much for the comment. Dr. Elkowitz, I feel like that's a whole other segment that you and I could have about the medical system. But any quick thoughts on Sarah's comments there before we?
Yeah, no, I hear what you're saying, and one of the things that one of the challenges we have as a medical school, especially in the first 2 years, we call it the preclinical years, is that we have a mission to make sure that our students are exposed to the medical material, the medical education material, and learn how to critically think, and that takes an enormous amount of time. But what we really try to intentionally do is make our students aware of all the societal issues. As they're learning about these cases, we embed them into their cases. They see a lot of these types of societal issues as they rotate with the ambulances as certified EMTs, when they rotate through the hospitals and their physicians' offices in the very, very first year of their first day of medical school. They are very, very much exposed to all of these issues that are being described. So we intentionally expose our students, and with the understanding that, medical education is not a 2-year or a 4-year deal. It extends into residencies, our Northwell's residency and fellowship programs, and even as lifelong learners as new attendings.
We have been talking with Dr. David Elkowitz, who is the Associate Dean for Academic Programs and Educational Culture at the Zucker School of Medicine at Hofstra Northwell. Dr. Elkowitz, also the director of the Academy of Medical Educators, talking about new approaches to medical school curriculum. Dr. Elkowitz, thank you so much for your time today, and we really appreciate it.
My pleasure.